I'd like to introduce our speaker today, Dr. Brittany Badal. Dr. Badal received her undergraduate degree in biology from the University of Central Florida before a medical degree from the University of Louisville. She completed her pediatric residency at Johns Hopkins All Children's Hospital and then a fellowship in adolescent medicine at the University of California, San Francisco. She joined our U of L faculty in 2021, where she serves as the clinical director of adolescent medicine, and she has clinical interests in eating disorders, addiction treatment, and reproductive health. Dr. Badal will be speaking to us today about substance use in teens. So I'm going to turn it over to Dr. Badal.
Hi, everyone. Good afternoon. I am so excited to give this presentation today because I know this is quite a hot topic for many of us in different clinical practices. Perfect. So first, I want to talk a little bit about just our overall objectives, because this is a topic that we could spend all day talking about. I first off have no disclosures to share with you. Our goals today are just to briefly talk about recent trends in adolescent substance use, identify adolescents with substance use using some evidence-based screening tools that we'll go over, and really review the current treatment options for adolescents with substance use disorders. So first off, I always want to start a talk around substance use disorders, right? About words, right? The language that we use, whether it's in the room, with the patient, with the family, with our colleagues, and even our documentation can be very stigmatizing. And so just wanted to highlight, the importance of using person-first language and that this is a person or a patient with a substance use disorder, and really thinking about the language that we use in our documentation as well. So let's talk a little bit about recent trends in substance use patterns. So the three most common substances used by teens continue to be things like alcohol, nicotine, and cannabis. We also know, right, that levels of especially cannabis and nicotine use have changed a little bit since the pandemic. We did see a little bit of a spike in 2020, and some of these levels have decreased a little bit since then in the most recent, like monitoring the future surveys that different high school seniors and high schoolers complete across the country. We know that opioids continue to be involved in a large proportion of overdoses in Kentucky. And I also just wanted to just briefly touch about xylazine. I feel like we're hearing about this in the news, right? Or maybe from some of our colleagues. If you haven't heard of xylazine, sometimes people will refer to it as tranq or tranq dope. And it's actually a non-opioid sedative or tranquilizer. But there is this concern, right, that there's been a higher proportion of illicit drugs on the market, different street drugs with a mix of xylazine and fentanyl, and that places those users at a significantly higher risk of a fatal drug poisoning. And that Narcan, right, which reverses opioids, does not affect kind of xylazine because it's not an opioid. And so just wanted to kind of to share that we're seeing, especially more in adult patients. But you may encounter this with adolescents. So I wanted you to at least hear about it. So the big thing that we still hear a lot about and is very popular among adolescents is, of course, vapes. There are so many different types of vapes out there. Just a few years ago, Juul was all the rage, right? But now it is a totally open market. There's these different like pre-filled pods that you may see, vape pens, you may see boxes, you may see these refillable devices. And so just wanted to highlight there may be a whole host of things that your teens are using. And sometimes it's not as useful for us to know exactly the specifics of their device, but mainly kind of like how often they're using. So we're going to talk a little bit about that today. I just wanted to share with you some of the trends over, that we're seeing with kind of youth. Now, this is from kind of that Monitoring the Future or Youth Risk Behavior Survey that really actually looks at 8th, 10th, and 12th graders. And so, of course, for things like vapes or e-cigarettes, right, we only started tracking this, gosh, in less than a decade ago, right? They haven't been on the market that long. But reassuringly, in some ways, we are seeing somewhat of a decreased level of at least like use in the last 12 months for our teens. And so in 2022, about a third of 12th graders had vaped nicotine sometime within the last 12 months. I always like to preface that this graph and the other ones I'm going to share are just like, have you used this in the last 12 months, right? I think sometimes that differs clinically from patients that we're seeing. Their level of use is maybe different, right? I think we can all kind of share those clinical experiences of teens, not just like, oh yeah, I vaped once with a friend, right? But they're maybe vaping every single day, multiple times a day, right? And so this is just kind of that prevalence factor. Also kind of looking at alcohol over the last, gosh, many years since the survey started. We see about half of 12th grade seniors have used alcohol sometime in the last 12 months, which has actually been falling pretty steadily in recent years and pretty steady overall, just in the last maybe 5 to 10 years. And then cannabis, right? We are hearing about cannabis every single day, kind of probably in the news, in the Kentucky legislature, right, from our patients. We're seeing about a third of seniors who have used cannabis in the last year or so. But again, right, this is just anyone that reports, yeah, I use that, not always their frequency, which can be a little bit different. Here in Kentucky, we know, right, we have been touched like every part of this country by the opioid overdose and opioid use crisis. So I just wanted to share kind of the most recent published data around what's happening in our region and in our state. And so this is from kind of the Kentucky kind of health information that's publicly published. And so 81% of Kentucky resident overdose deaths in 2020 did involve opioids. This is kind of a map that shows kind of the rate of opioid overdose deaths by county. And the big thing to highlight, right, is that even just in the last few years, the number of people being affected by fentanyl has significantly skyrocketed. And so, anytime I'm talking to any of my adolescents, young adults, their families, I really want to highlight that I pretty much tell them, if you are getting anything off the street, you can almost guarantee there's probably fentanyl in that product. And that's what we're seeing kind of nationally. And so I think it's just something that we do need to be counseling about that if that arises at all. And also to highlight, right, that especially adolescents, they may not be using opioids, right, every day, right? But they may be trying it at a party. They may be trying it in a different social setting. And so just really making it clear to them, you don't know what's in that product, and that fentanyl has been laced with many things on the street, opioids included, as well as different stimulants, amphetamines, etc. So the big question is well, in pediatrics, sometimes we're like, whoa, 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 this is an adult problem, right? That's something that the adult docs deal with. I just don't feel comfortable as a pediatrician. And I totally want to be here to echo that, right? Many of us, we don't always get substantial training and exposure, right? Especially maybe in our training backgrounds. But this is something that I really want to encourage you all to become a little bit more comfortable with. Because we know, right, from the study published several years ago, right, that the chances of developing an addiction or a substance use disorder are 4 times higher for people who begin using substances before the age of 15, as compared to those who delay use until 21 or older. And as the residents know, I always talk about this. Anything we can do to delay that age of initiation of a substance actually decreases this risk, right? And so, really talking to our patients about it. And if they've already tried a substance, okay, really let's talk about like decreasing risk. Let's talk about health consequences. And because we really do want to be on the forefront of prevention. That is what we are really, really good at in pediatrics. Adolescence is a really crucial time. I found this study really interesting, that they looked at kind of high school seniors that had been surveyed nationwide by the National Institute on Drug Abuse in the Monitoring the Future study, some of the data I just shared, right? And they actually followed this cohort from teens that had completed this survey in the 70s and 80s when they were 18 to when they were 50 years old. And they did see that for most of the individuals who had a severe substance use disorder and symptoms of that in high school, they still had some of those symptoms later on in life, right? And those with the highest severity use kind of in adolescence had the highest likelihood of prescription drug misuse decades later. And so we know we get excited in pediatrics when we think about, I can change the outcome of this young person's life. And so I really want you all to think about what are the things that you can do, right, to try to move the needle forward. Right. It's really hard with teens, but it is something that's really important to our practices. And this graph really just kind of demonstrates, right, that we know the earlier age of kind of use, whether it's nicotine, alcohol, or other illicit drugs, the higher likelihood of a abuse or dependence or a use disorder later on in life. And so, though this talk is not going to go into all the details of like, you need to now go diagnose a substance use disorder, I do think it's really important to talk about what qualifies as a substance use disorder. So use disorders are really characterized by, of course, we think about things like drug cravings, right? Or a loss of control over drug consumption. And that can mean spending a lot of time spent getting a hold of their substance of choice or using that substance, and then continued use despite negative consequences, right? So I always think about the consequences of a use disorder really involve a failure to fulfill work obligations, or for many of our teens, school obligations, or home obligations and expectations, and the development of social or interpersonal problems. Of course, if a young person is experiencing some type of physical harm, maybe that could be worsening of their asthma, more exacerbations because of their smoking or their cannabis smoking use, psychological harm, right? And then, of course, we think about tolerance and withdrawal. And so why is this really, different sometimes in adolescents versus adults? You know, um, I will not bore you with kind of some of the real nitty gritty of this, but the thought is that there's really that big change of executive function, and adolescents compared to adults, right, are a little bit at a deficit. We know this about our teens, right? They don't always have the best future orienting kind of thoughts, right? They're not always great at all the executive functions that are required of adulthood, right? That front part of their brain is still developing. And so we think it's really mostly affected, especially with any type of substance use, that they have really poor executive control in these different areas of their brain, right? Kind of highlighted here, that really allow substances to create that reward center pathway and to strengthen that connection, because it's like, oh, I really like the way that makes me feel. I'm going to keep going back to it, without having some of those future thinking abilities to think about the negative health consequences, or even the foresight to think about how it is negatively impacting their life. So I've talked about why this is really important, but you all are probably wondering, okay, cool. So I should do something in my clinic, but like, what does that practically mean? So I did want to spend some time today really talking about screening, right? The AAP recommends universal screening in the pediatric primary care setting for teens 12 to 17 years old. So we are going to talk a little bit about some different screening tools. But first off, let's talk really about the approach, right? Because teens can be, a little weary when we bring this up. And so sometimes you might want to say, hey, as a way for me to get to know you, I want to ask you questions that I ask all of my patients. Is that okay? Um, if you start opening the topic of substance use, they might be like, well, why are you asking these questions, right? I think normalizing that you ask everyone about their use of, alcohol, nicotine, marijuana, other substances, because, it's our job, right, to think about their health first. And we want to be sure that we can kind of help guide them on that journey, right? And also reassuring them that whatever the information they tell you is confidential unless you worry about safety, and kind of proceed from there. I do want to pause to think about the safety piece because, as many of you are probably aware, right, in the state of Kentucky, there is some confidentiality permissions for allowing teens, especially above the age of 16, to access, sometimes it's labeled as like drug abuse counseling. I have found that in practical terms, that can be really challenging, right? We all know how hard it can be for teens, first off, right, to find any kind of counselor or therapist. So it's really great, I think, when teens have access, maybe in the school setting, to be able to talk to their school counselor, or maybe they have in-school therapists about maybe some mood things that are going on. And maybe they can talk a little bit about, like, yeah, I've been smoking weed a little bit, and that can remain confidential. But in practical terms, for really getting teens access, especially if you think they have a use disorder, that is something that should be disclosed to their families. And so I always preface my confidentiality spiel with, like, whatever you share with me today is going to stay between us unless I'm worried about your safety. And I think, pausing with yourself to think about, where do you draw that line for disclosure of safety? I think all of us around like suicidality, that's pretty clear, right? We know if someone's having active SI, we of course are going to talk to their parent or guardian. Around substances, I will share with you personally, I do have some variance in, if someone ever tells me that they've tried an opioid, I'm going to pause there because the risk of overdose is just so high. I do think that's something we need to bring their parent or guardian into that conversation. And so just really thinking about, where do you draw that line for yourself? Because there is no always like black and white answer to that, but thinking about how you can approach all of your patients in a similar fashion with trying to decrease your own implicit bias. So thinking about it beforehand can be quite helpful on, like, this is how I would handle this topic. Okay, so let's talk about some screening tools. You have to remember that the goals of screening are really to keep something brief in the clinic, something that's been validated. It should be easy to implement, and thinking about, oh, what are those next steps? And so we're going to touch briefly on some of these tools kind of here, especially like the S2BI, which is the screening to brief intervention, the BSTAD, so the brief screener for tobacco, alcohol, and other drugs, and the CRAFT. I really like these tools because you can think about what's going to work best in your own practice, right? Is this something you're going to give on paper? Is this something that is electronically built into the EMR? I will say, like, here with the Norton, Craft is built into a flow sheet, and that thing can be quite nice. But thinking about, how are you going to implement that, within your clinical practice? Are you going to ask those questions? Are you going to give them a paper screener as they're getting roomed and checked in with your nurse triage? But all of these tools should take easily 5 minutes or less and have pretty limited amount of questions. And then if there's some positives, you may want to spend some more time pursuing kind of next steps and asking some further questions. I think it's always really important too that we are really great at motivational interviewing for lots of things in our practices. And so don't forget, you have really great skills in this area. You're just applying it to in a new way. And so always remember, if you do get a positive screening, it's really important to offer some brief education about the risks of substance use, right, with your patients. Have really a patient-centered discussion, trying to employ some MI principles to really think about if you can get them to reflect on what things they don't like about a substance. And we're going to talk a little bit about that too. But this really can occur anywhere from like 3 to 15 minutes, and can be done in the same session as the initial screening. And it's okay to like keep following up with them, right? If we just talked about it once and we may not get anywhere, but it's okay, to keep checking in. I always describe teenagers are sometimes like icebergs, and you have to slowly chip away to really get at the meat of things. And if a patient is ready to accept treatment, really consider making a referral, and that really can be a proactive process. I always think about what about those high risk substance use? You still want to do a little bit of a brief intervention, things like the ORS framework for opioid use and other motivational interviewing techniques. Really provide some feedback and advice. Try to set the goal of abstinence or even talking about cutting back, and really, ask them, do your parents know about the substance use? I think we really need to bring your mom or dad into this room. How can that look, right? And really think about, is this someone, depending on your level of concern, that could navigate a referral on their own, especially if they're 18 or 19, that may look a little bit different. So let's talk about the screening tools. So with S2BI, you guys may have seen this before, but really the three main questions are, hey, in the past year, how many times have you used any of these substances, right? Trying to get a little bit of frequency. And then, if they've answered yes to any of those, you want to think about prescription drugs, illegal drugs such as cocaine or ecstasy, inhalants, or herbs. And this is sometimes where like K2 and synthetic drugs may come into it. But the workflow for STBI can go everywhere from no use, right? Just really positively reinforcing that, to say like, wow, you're making some really good choices, right? Because first and foremost, our goal is trying to prevent and trying to just like reinforce you're making some really great choices for yourself to delay that age of initiation of trying anything. If they are using it all, thinking about, oh, if this is just once or twice they've tried something, maybe we can give them some brief advice, right? The best thing is to not use. There's health risks involved. And, let's talk about, strategies that you can use in social settings. If, we're getting at monthly use or even more frequent, like daily or weekly use, I think that is a time to kind of assess for how is this impacting your life, right? Our recommendation is, of course, to quit, and like, let's make a plan to try to reduce use, reduce risky behaviors, and refer to treatment. I also want to talk about the BSTAT a little bit, which is the brief screener for tobacco, alcohol, and other drugs. And I think this is where many of us, when we go to do a social history taking, sometimes, especially for our younger teens, it is recommended and it's okay to first ask questions about their friends' use. Or I found some success in asking about like, oh, at your school, do you see people that vape? And kind of building and then to like, what about any of your friends? Have you ever tried anything? And then kind of go into kind of personal use. And of course, that's different in our older teens, right? But if a teen responds yes to any of those questions, you really want to think about, expanding from just like more commonly used substances like nicotine, cannabis, et cetera, into some more of the illicit substances that we've kind of highlighted here. And you really want to think about, when was the last time they used? In the last month, in the last 90 days? Was this a year ago? How long ago was that use? And so this is a little bit what the BSTAT looks like, if you're familiar with this. So really, this highlights that younger adolescent, like, oh, friends, you have friends that smoke, tobacco products. You have friends who drink alcohol. Do you have friends who have used any of these substances? And then really getting into their personal use. For me, if it does come up that maybe in their school setting or their friends are using something, but they have not tried anything, really congratulating them and saying like, hey, if somebody offered you something, what would you say to them? Especially for the younger teens. I think, if you have that like 1 or 2 minutes for them to think through what they could say, again, you may be able to delay their age of initiation. And so for any of those questions, if they're positive, it will kind of go into some of these further questions. And so thinking about how you can integrate this maybe into your screener for your well adolescent visits, while they're in the waiting room. Maybe their nurse gives it to them while they're kind of, waiting for you to kind of enter the room, and then you can use it as a jumping off point. Some of the data really shows that depending on how they report, if they report just one day if they've tried something, that's maybe a lower risk, of course, than someone that's used it, more than 2 days. And for tobacco, historically, the study was done on like at least 6 days, and that was a higher risk level. Of course, the craft, many of like the S2BI or the B stat may lead into the craft. In my clinical setting, I typically just start with the craft, and I have found that can be like just a really good segue into it. I always find it funny, just as an aside, when I give paper screeners in part A, sometimes I'll have teens with pencils that will clearly write a number and then try to erase that number and leave it blank or write a 0. And I still always like to check in with them, be like, tell me more about this. Um, but this really gets at, an estimation of about how many days do they think they used alcohol, cannabis, or anything else. And I think this can be really telling, if you see things like 2 versus I've seen 3, 6, 5, I've seen, 100, right? Just trying to get at what that level of use looks like. And so part A will then kind of lead into part B. And many of you may be already using this in your practice. But the craft actually stands for C is for car. So have you ever driven, or somebody else has driven you that's been under the influence? R is to relax or feel better about yourself or fit in. A, alone. F, you forget things that have happened under the influence. And then the other F is for family or friends ever concerned about your use. And T is trouble. And I think the thing I always like to highlight is sometimes teens will be like, no, it's not a problem. But if you really dig, like, oh, yeah, like, oh, well, you're no longer on the basketball team because your GPA dropped because you're smoking weed all the time, right? Your mom is upset with you all the time, right? And she's worried about your use, right? If you really kind of dig, you can find negative aspects of their use and how it's impacting their life. But teens, different than adults, are not always going to come to the table and say, I have a problem. And that's where our jobs can be a bit more challenging. I really like the craft because it has a really great validated screening tool. And I just want to highlight that, the more positive someone has on a craft, the higher probability they have of a DSM-5 substance use disorder. And so really, if you do have young people that are scoring 5s and 6s, really thinking about, are they open to a referral today? And we'll talk a little bit about some local treatment resources too, but just really checking in with them is important. For kind of the counseling piece, if you do get some positives, I think it's always important to, just review it with them. And sometimes I'll just kind of show them their paper screener and be like, tell me more about this, right? Keeping it really open-ended. They can share lots of different information with you. I always make a strong recommendation like, hey, I'm your doctor. My job is to keep you healthy. These substances are really dangerous to our health. Whatever kind of works for you, thinking about how it's interfering with their brain development, interfering with learning, putting them in dangerous situations, right? But we do have to acknowledge that not all of our patients, right, are going to immediately stop using because we tell them to. And so really doing some risk reduction counseling. So the big thing, right, we know motor vehicle accidents are still a leading cause of death. And so really talking to them about like, okay, how do we get you a safe ride home? I always joke with my patients, that's what Uber and Lyft was designed for. Do you feel like you could call your mom or your dad? What would that look like? And then also, as we talked about, for those non-users, can we create that statement of like, if someone asked you to drink or someone asked you to smoke, like, what would you say? And really try to reinforce the positives that they are doing, even if it's a small change. Maybe they were smoking every day, but now they're only smoking on weekends. Like, that's huge, right? That is change. How can we positively reinforce that while also balancing that with the message of like, the best thing to do is not to use, and how can I help get you there? Yep. And so really the screening tool can be a great jumping off points to really give feedback about how that substance may be affecting their overall health and their trajectory. And so you do always have to balance this with, we know teens are not, open to like a lot of finger wagging. And so, I think anything you can do to try to partner with them about like, hey, like, I'm just worried about how this could affect your future. I know you want to go to college. I know you're about to graduate. You're going to go get your first job. Like, I know, never want these things to get in the way of you living your best life. And so trying to deliver those health messages while still remaining a partner in their care. And also, think about, focusing on those social and family impacts that the substance use may be having on the teen rather than just their physical long-term health, because many of them are not going to care too much about like, oh, like, they have that like nothing bad will ever happen to me. Like, no, my asthma's fine, whatever that might be. And so, of course, just to highlight, the first step is always reminding them that not using is the safest option. And I have found too, most of my teens are pretty open before I deliver some health messages. If I'm like, oh, tell me more about this, and I'll just ask permission. Can we talk about, your cannabis use today and ways to like help keep you safe, and just asking for that permission piece. Like, we know an MI can leave them a little bit more open psychologically to receiving our message. And I will say, people always get worried, what if they say no, right? It's possible. I will say the vast majority of the time, my teens are like, sure, right? And they're pretty open to hearing it. Every once in a while, if I do have someone that says no, I just try to lead with, that's cool. You're not in a place to talk about it today. I'd like to check in about this in the future with you. Is that cool? And just letting them know you're going to keep checking in. I always want to think about, how we can reduce harm and try to get to a place of engaging in any kind of change talk, right? And so you can lead with, I'd like to talk about safer ways to use today. Are you open to talking about it with me? If they're like, yes, okay, great. You want to start with talking points regarding what is their current use? What are some ways to keep them safe, right? Especially when we were talking about like driving under the influence. We always think about alcohol, but, especially with cannabis too. And if they say no, even leading with like other people, right? Do you know about ways that other people keep themselves safe while using? And kind of trying to allow them to talk about friends or peers, right? And sometimes they feel more comfortable kind of sharing that information. I know many of you have probably been in the situation where they're just like, no, it's not a problem. No, I don't want to talk about it. Like, I can stop anytime I want, right? And so some patients are just not going to want to engage in conversation regarding their use. Or there's maybe the concern about, is my physician, is my provider going to disclose? Am I going to get into into trouble or legal trouble? And so sometimes when they have no concerns about their use at all, I'll switch to some hypothetical situations. And so I may say something like, some of my patients have, concerns they might do something when they're drunk or high that they regret later. Or some of my patients think they're spending too much money on vapes. Some of my patients are scared that their friends are going to drive drunk or high, and just kind of trying to use a little bit of the other to kind of bring in, like, when that comes up for those patients, this is what I tell them, right? To try to open that discussion a little bit more. I think the most important thing is, we talked a little bit about the criteria for a substance use disorder, but actually trying to keep this pretty conversational. Uh, no one wants to feel like they're a checklist, and that's really hard when we're busy. But if we are concerned about the use, trying to keep it conversational, trying to keep that alignment as much as you can about like, I am here to help, right? And really leading back with like asking you about the positives and the negatives of their use. Recommend abstaining. And if they're not ready, trying to set a goal with them to cut back. And so I'm all about using those SMART goals, right? Where I try to have the team set a really specific goal with me. And like, when are we going to check in about it? And we just keep reassessing, right? Small baby steps forward. So I do want to just take a moment now that we've talked a little bit about that and just share a little bit of a case that might be helpful to put this in real practice. So you have Eric who presents. He's a 16-year-old young man, has a past history of some mild intermittent asthma, who presents for his annual well visit. His dad reports that this year his grades have worsened and he worries about his upcoming application to college. So, we independently, want to try to get any time with our teens, right? We find out Eric is smoking cannabis. When you ask about like, okay, well, how do you smoke, right? He reports that he's been smoking blunts 1 to 2 days a week, right? And sometimes it may be helpful to ask about like, oh, is this a blunt? Is this a joint? Is this a spliff, right? Because some of these products may also have tobacco in them, and thinking about that nicotine aspect. And so just important to think about like, ooh, are they dealing with cannabis and also nicotine? We always want to ask about how often are you using, right? Sometimes it can be helpful to also ask about like, oh, when did you first start using? And has this changed over time? I have many teens that tell me like, oh yeah, like Eric, right? I first used at 15. I was using maybe occasionally every few months with friends socially, but then I started feeling more anxious. I started, now I'm using every week in the last few months. And so even them just sharing that journey, it gets them to kind of share out loud and reflect on, oh, I am using more than maybe I ever thought I would be, right? Um, and so I find it really important to also ask about, what do you think this is helpful for, right? I feel like many times, especially with cannabis, I get patients that tell me like, oh, it really helps me sleep at night, or it really helps my anxiety, helps my mood. Before I ask about like any negative effects that they've experienced, right? Eric, in this case, right, shared it helps him sleep, helps when I'm feeling stressed. But yeah, it's led to me missing school assignments. It's led to me skipping class to use with friends, and I do worry about my grades. And so, if I know kind of why they think it's helpful, sometimes that can be an opening point to think about, well, why don't we do something evidence-based for your sleep? Let's do something evidence-based for your mood. What about counseling? What about therapy? Would an SSRI be helpful, right? Thinking about like, you're having this problem, I want to help, and also kind of cut down on your use. So anything we can do to get young people to engage in change talk is going to be a win. Even if it feels like the smallest one in the world, it can be a really great jumping off point for people. I also want to highlight, if you're looking for some youth-centered information, I really like Truth or Nah, SF, as in San Francisco, truthorsf.org. Specifically, it was made for cannabis, but has a lot of like myth busting and some facts to share with teens for some really common myths that teens hear and that we all hear in pop culture about cannabis. I think the most important thing is to really think about meeting the adolescent where they are, right? This does not always feel like the ultimate win at the end of the day, that you're like, that patient was using every day and now they stopped because I told them to. You are going to have wins, right? But sometimes it's really slow. And so at different times, people are going to feel more or less motivated to change, right? Um, uh, but we can be thoughtful about how we can counsel them to reduce harm, right? Even if they're pre-contemplative about stopping use altogether. And even if, in different substances, if they're not planning to quit or cut back, thinking about ways to protect themselves. So I wanted to spend the next few minutes just briefly talking about some treatment resources and some guidance. And I want to highlight, we could again spend a whole day talking about different substances. But I really want to highlight some of the most common ones that we see in our practice. So first, let's talk about nicotine replacement. Um, there's always been this question around, can adolescents use nicotine replacement therapy? And still, I do want to highlight that the FDA still has not approved NRT for youth under 18. But there's been more research that's come out on the effectiveness of nicotine replacement therapy for really helping youth quit. And overall, historically, this has always been a little bit mixed. And so for a while, it's been like behavior, 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 which I really want to stand by because that is really important. But there's also no big evidence that shows that NRT causes serious harm for adolescents. And so just recently, the AAP has come out with a new policy recommending that pediatricians consider off-label nicotine replacement therapy for youth who are moderately or severely addicted to nicotine and they're motivated to quit. Because I do want to highlight that with the increase in electronic like vapes, right? The level of nicotine that youth are using is just much higher than maybe historically with cigarettes. Though Juul has fallen out of favor, right? And these pieces, I always like to just like reference that, like, for example, one Juul pod had the same amount of nicotine as a whole pack of cigarettes, right? And so if someone was going through a pot a day, that is a pretty significant nicotine tolerance level. And so if you are thinking about using nicotine replacement therapy for youth under 18, they do need a prescription. And just remember, just like in adults, non-adherence and relapse after cessation of nicotine is pretty common. And so trying to establish some follow-up. I just want to just kind of share, if you're not super familiar with using nicotine replacement therapy, I like this graphic because you do have to think about using a long-acting form with a short-acting. So before the days of smart asthma therapy, I liken it to asthma controller with a rescue, right? That you want to have a nicotine patch for that long acting, and then a short acting that usually can be like a gum or a lozenge, but just really to allow them to meet their cravings. And so this also just highlights there's different options out there. So really thinking about what's going to be best for that patient, right? If you are going to do a nicotine replacement patch, I do tell patients like, yeah, you could wear it for 24 hours, but you might want to take it off for sleep because some people do report some vivid dreams. And then thinking about what's going to be best for them around short acting. Is that going to be like a little mini lozenge or a gum? I think just also highlighting the gum is different than just usual like chewing, like bubble gum, that you do kind of have to chew and then kind of park it between your teeth and cheek to have best effect. So just important things to kind of know. People always want to know, what are the contraindications? I mean, of course, the only true contraindication is an allergy or hypersensitivity to nicotine, but you do want to be aware of any disease-related caution around cardiovascular disease, diabetes, or hyperthyroidism. But these are relative, kind of relative cautions and not absolute, and you have to balance that with their current continued tobacco. And so just did want to highlight the AAP with that new policy did come out with a little bit of a toolkit. So this is from them that really we should, of course, counsel all patients who use tobacco or nicotine about quitting, regardless of the amount. And so some different statements and really trying to use that strengths-based perspective, that non-judgmental language, and maybe like examples that are important to them. So, if they're an athlete, better athletic performance, right? Not, especially for teens, I have found, right? They do not like spending a lot of their own money. And so like asking like, well, how much money are you spending? Wow, those companies, they're just taking you for a ride, right? Like no one wants to take advantage of this financially, especially teens. And so sometimes that can be a good way to think about what else could you spend that money on, and really trying to link them to appropriate behavioral supports. And so these are some recommendations from that toolkit. So like texting the quit line. There's a great kind of some great online resources with teen.smokefree.gov. And if you are interested, you can totally check out the AAP Help to Quit website. They have some really great things. And then I usually, if I'm starting someone on NRT, I like to see them in 4 to 6 weeks and just like keep checking in about that piece and thinking about their step down plan. Cool. So transitioning from nicotine to cannabis. I really want to highlight, right, that cannabis withdrawal is real and we need to normalize this for patients. Now this is different. When we think about withdrawal, right, we think about alcohol withdrawal, we think about opioid withdrawal, benzodiazepine withdrawal. Patients that are typically more adults, right, that need inpatient detoxification. Cannabis, luckily, does not require kind of inpatient medical stabilization. But I think talking about it with our patients can be really helpful and normative because, right, we're telling them to cut back. We're telling them to quit. They may experience some of these things and just normalizing that for them, right? And so this is one study from 2017 showing that as people kind of stop their cannabis use, they can experience things like sleeplessness, sweating, appetite changes, headaches, some nausea. And typically these get better within 1 to 2 weeks. And that's how I counsel my patients. We know that this is common, especially for about half of regular users, and for very heavy users, about 80% of them. And so they may experience some irritability, some anxiety, sleep changes, some mood changes. changes in their appetite, and that this typically does get better and resolve over about 1 to 2 weeks. And so I think sometimes the challenge is getting patients to believe that this exists, or if you've ever talked to them about like, hey, what would it be like to go a week without using? Sometimes I use that as a strategy. If they're like, I use every day, I could quit anytime. I'm like, okay, cool, cool. So like, what would it be like to take a tolerance break? And checking back in them and be like, hey, were you able to stop? What did that feel like? And they may say, oh my gosh, I felt kind of crummy, right? And really getting them to buy into the fact that like, oh, your body's pretty tolerant to this, right? And that this is really secondary to your cannabis use. Because many times, right, in pop culture, we hear about like, oh, you can't become addicted to cannabis, right? And so really talking about what are those physical effects that can happen. Um, I also cannot leave out like high risk substances. We are lucky that this does not happen at the same rates of things like alcohol, nicotine, or cannabis, but it is something that we are seeing in our practices, right? And so if someone really is using things like opioids, benzodiazepines, stimulants like methamphetamine regularly, I would urge you to consider, does this patient need inpatient admission for acute detoxification? Just with some of those risks involved, especially in pediatrics, right? And you may see some changes happening in the next few months locally to some of the services that we can support teens with. And then, I think it's always really important to try to get that detailed history, including when was the last time they used, right? Have they ever overdosed? Have they experienced withdrawal? And really getting that really detailed HEDS or social history assessment, thinking about, especially like homeless teens, is this a housing challenge and they're using and they're on the streets, right? Are they sexually active? Are we concerned about any type of neglect, abuse, trafficking? I'm thinking about their mental health status and any suicide risk. It's most important, of course, to do a comprehensive physical exam and thinking about some other lab screening, right? So if you're doing a urine drug screen, that should always be with their consent, right? And thinking about what are you going to do with that information. Checking a CMP and LFTs can be really helpful, right? If they're at risk of pregnancy, checking a pregnancy test, and depending on their use and their other factors that come up in their social history, screening for HIV, other STIs, syphilis, and hepatitis C. And if they're not up to date on things like Tdap and Hep A, trying to get them up to date. I also really want to talk a few minutes about Narcan and why this is so important, right? We know that this is from the published data from the CDC and the morbidity and mortality report just through 2019 to 2022. And 60% of youth that were between the ages of 10 and 19 years who died from an overdose did so at home. 2/3 of the time, a caregiver was present, sometimes in another room, and unaware of their use. That is terrifying, right? And so, we want to think about what we are doing as a community to try to normalize having Narcan access. We know that Narcan was administered in only 30% of those cases, and 2/3 of these teens had no known history of opioid use, and a vast majority had no overdose history. About 40% did have a history of mental illness, but only 3% that overdosed were engaged in any type of treatment, and only 11% ever had any substance use disorder treatment in their life. And so, really thinking about how can we normalize with teens and families, right, to have access to Narcan. And that's why in my practice, if a teen ever discloses they have ever tried an opioid or an illicit opioid, even once, I really want to involve that parent, right? Even if they are not using every day. And so as we think about Narcan access, I just want to remind you all, it is now available over the counter, but offering a prescription may really improve that affordability. I know at my local CVS, they keep it behind the front counter. And so just kind of finding out what that looks like in your local area, right? I also wanted to provide some resources if you're trying to think about how to get patients connected to Narcan. And so this is 2 different websites. There's if you just Google literally like Narcan in Kentucky. You can find yourself to get these websites, but through corrections offices, you can actually get Narcan for patients and their families and whoever may need it. And then nextdistro.org has some really great resources as well, and will mail kind of this nondescript package to people's homes. And so that can be a really great way to try to get it to their door. I also just wanted to spend one moment just talking about opioid medication assisted treatments. These are things that we've all heard about, right? Methadone, buprenorphine, and naltrexone. These each work a little bit differently. Everything from a full opioid agonist in methadone, and that's typically for 18 and older, right? Buprenorphine, which is a partial opioid mu agonist approved for 16 years and older, and naltrexone, which is an antagonist. And so as you're hearing more and more about buprenorphine, just briefly wanted to touch about how it works and how it's different than methadone or naloxone, right? That it's typically that partial agonist. And so this little graphic here shows that it will kind of bump heroin from those mu receptors and has a pretty high affinity for opioid receptors to really block those euphoric effects that lead to that positive reinforcement of continuing to use. It does have a ceiling effect, so increased dose does not increase the same opioid effect, and that's part of that partial agonist pharmacology. And really, when you combine it with naloxone, it tries to block all other opioids from the system. And that's why this medication actually has to be given sublingually. And so if you do see, whether it's patients or like families or parents that are in treatment, that can be an important piece to know. I really just want to highlight like why this really is one of the standards to really think about medication-assisted treatment, because this study, which was done in Sweden, really looked at individuals that all had the same psychosocial and therapy supports and kind of their time remaining in treatment for substance use and opioid use disorder. And we know that patients that received the placebo, 100% of them fell out of treatment, typically, as you can see, within less than 100 days. Where different than buprenorphine, only 25% of those patients fell out of treatment. And so just really highlighting that this can be a really effective option for patients. And if you all didn't see, I think Medscape just published an article about pediatricians not always feeling comfortable with opioid use or misuse and opioid use disorder, which is no surprise, I think, to all of us, right? But this is, just really important to think about how we're treating especially our older adolescents differently than sometimes adults. But in one study, that looked at youth 13 to 22, so that did include some young adults, 75% received any kind of treatment within 3 months of an opioid use disorder. Most only receive behavioral health services, so about half, and about a quarter receive opioid use disorder medications. But again, we know that retention and care among youth who receive timely buprenorphine or naltrexone is longer than youth that only receive behavioral health services. And so this is not to highlight that we shouldn't do behavioral health services, but really to think in people that are good candidates, how we can augment that. So I just wanted to put some resources here. I love the PCSS. It's a great website. They have a ton of information about opioid use and treatment for physicians and providers, as well as other substances. So just wanted to put it locally, some community resources that you all probably heard about. There are some great programs at the Brook, and thinking about like Crossroads and their adolescent intensive outpatient program that can address substance use, right? In addition to other comorbid psychiatric diagnoses. Always, of course, thinking about Peace Hospital. 7 counties also has a similar kind of IOP. And then, those of us in addiction medicine and adolescent medicine, we are always happy to help if there's a complex situation and that needs a referral, and really leaning on our psychiatry colleagues that are experienced with addiction, because most adolescents, just like adults, may have some comorbid psychiatric diagnoses that also need to be addressed. I also wanted to highlight, this is a different craft, but craft for families, which is community reinforcement and family training, can be a really great option. This is one workbook that's put out by the team that uses craft, but really trying to help family and friends use evidence-based skills to help a loved one getting into treatment. And so if you haven't heard about craft, it really tries to help families support their young person or our patient with getting them access to treatment. And we know families using the craft approach actually have a rate of getting them to treatment 65 to 75% of the time. And so it can be quite effective. And so that can be a really good resource for families that are really trying to help get their youth into some type of treatment program. And there's some information about that. Well, now that I've talked your ear off, I will pause. I think we have just a few minutes for questions, and I'm always happy to be a resource. So thank you all for attending.
Thanks, Dr. Badal. That was very interesting. Couple questions. Are there differences in substance use and misuse in the United States versus European countries where the drinking age is younger?
No, that is a great question. I think I will say I'm not an expert on European kind of data, so I would have to look into that. But their approaches are a little bit different, and also highlighting that they have very different like psychosocial supports for people that are using. So we do know that in the US, traditionally, there are higher rates of things like binge drinking in kind of our older adolescents and young adults. But as we saw, like some of the alcohol use overall is falling over time. I wish I knew the European stats off the top of my head, but I do not. I apologize.
All right. Do you recommend Effexor to help with smoking cessation for those anxious teens?
That's a great question. Yeah, I do think there can be a role for different medications, right? Like Effexor that have some evidence for it, as long as like otherwise they are a good candidate from like the mood perspective. I'm all about how can we get multiple benefits from one medication? So I do think it's a reasonable thought. Yeah.
Okay. And in screening adolescents, do you feel like our community has the resources necessary to really address all of this use?
Yeah. I think this is a huge ask. I think many communities in our country are asking themselves, right? That we are trying to meet a need. But, I always want to highlight, like, how can we really demand that we have better access to programs? Because if we're never even screening to pick up on people, how do we know who we're missing, right? To advocate for change. And so though, right, like we I think are in the process, especially now as Kentucky and like the city of Louisville, like are getting different funds from opioid settlements, right? Thinking about how we build evidence-based programming, we really like, what is that need, right? And unless we're screening and making referrals and trying to get people connected, we're not maybe even like identifying these patients, right? And I think we're doing them a disservice. We may not have all the tools in our toolkit, right? That's why we have other partners and people we can refer to. But if we start asking the questions, we may sometimes be surprised at things that we find.
And as you alluded to, we can now occasionally see the adolescent who needs inpatient acute detox. Who is the expert really that we need to contact? This is not something that's really been in our wheelhouse in the past.
Yeah, it's a great question. I am always happy to be a resource. I know Dr. Kelly Cooper with Norton Adult Addiction Medicine is also happy to be a resource. And I don't want to like, it is not ready at this moment, but coming in the next few months, there is a large group of us working at Norton Children's to bring things like Suboxone inpatient and have a protocol to help manage these patients. And so we are always happy to be a resource downtown as well.
Great. That would be very helpful.
Yeah,
Okay.
it's coming.
All right. Whoops.
Perfect.
Oh, what happened there? All right. Sorry about that. I think we're out of time. So thank you so much, Dr. Badal.